Thank you, Valerie. It's me again. Got to get Valerie to introduce me rather than introduce myself. So, this is a study that we've been recently involved in. I'm very pleased to. I'm going to present this with my recent BSc student, Arjun, sitting over there. He's going to come up on stage in a bit. And I'm presenting this on behalf of our group at Imperial and Professor Mireille Toledano, Professor of Epidemiology, who's collaborated with us on a lot of epidemiological studies. So this is a very preliminary analysis of healthcare factor differences between high and low incidence areas of cholangiocarcinoma in England. So we've already had an introduction about what cholangiocarcinoma is. It's a cancer arising anywhere in the bile duct, the lining of the bile ducts, which can be within the liver or just outside the liver. Now, 2 or 3 years ago, as Helen mentioned, we did a large epidemiological study of NHS data around the UK, where we looked at the incidence and mortality. So just a reminder that incidence is the number of new cases, new diagnoses made per year, and mortality is the number of people that pass away from the condition. And we looked, and we divided the country up into 20-odd geographical areas based on cancer alliance geography. And we found that there are some parts of England where the incidence and the mortality of cholangiocarcinoma is higher than others. And this was a very sort of novel type study, because there have been lots of studies in the literature that show in many countries cholangiocarcinoma, particularly the type that arises in the liver, so-called intrahepatic, is going up. But no one had really published a deeper dive into, well, within a country, are there regional differences, until this study was done, which was done with AMMF and commissioned by the AMMF. And we also found, it's not the topic for this particular talk, that there were differences in access to treatments, and a substantial amount of patients didn't get any cancer-specific therapy. So if we look at the maps of England between 2001, over a 3-year average, 2001, 2004 on your left, and then compare that to 15 years, 17 years later, 2015 to 2018 on the right, you will notice two things. One is that the map of England has overall got darker, and the darker the colour, the higher the incidence, the number of new cases, and the higher the mortality, the number of people passing away from cholangiocarcinoma. So the map of England has got darker, suggesting cholangiocarcinoma has increased. And the other thing you'll notice is that some areas are darker than other areas. So this was all published in the scientific medical literature. So then every time you do any research, it just raises more questions rather than actually answering questions. So we wanted to have a look at what is driving this regional variation. John, do you want to come up now, or do you want me to carry on? You come up, come on. Okay, so Arjun was a BSc student at Imperial and did this data analysis, and I'm going to hand over to him and I'll come back at the end.
Thank you all for having me today, and good morning. Our big question, kind of leading on from the most recent update and the most recent literature that Professor Khan carried out a few years ago, was what is driving this regional variation. We were first thinking about differences in management, which we have already referenced, a postcode lottery, or potentially a variation in data collection. How we're identifying and labeling cholangiocarcinoma incidence and mortality throughout the country. But what we instead decided to focus on within this study and my project was the socioeconomic and some of the lifestyle factors that could potentially be associated with cholangiocarcinoma. That led to the aim of the study, which was to compare socioeconomic and other risk factors to cholangiocarcinoma mortality, specifically, across the 21 cancer alliances of England. So in terms of our data collection, our cholangiocarcinoma data was gathered through the original study with Professor Khan, Tataru and Khan, and this was in turn from the cancer registration data set from NHS Digital. Our risk factor data was from the Department of Health and Social Care website, Fingertips. And for those who don't know, this is a free-to-access website with a plethora of risk factors that you can use to track loads of different socioeconomic risk factors just across the country. You can see our two websites here as well. But we did encounter a quick problem early on, which was that our cholangiocarcinoma data was split into 21 cancer alliances, as already mentioned, but the risk factor data on Fingertips was split into 153 counties and unitary authorities. We can visualize that here. So it was quite difficult to compare and contrast what was going on here and how risk factor data may actually relate to the cholangiocarcinoma mortality. Luckily for us, though, as we can see here with Cancer Alliance number 8, and this was similar across all of our cancer alliances, the counties and unitary authorities mapped up really well. So we individually mapped and labeled all of our counties to a given cancer alliance, and this allowed us to therefore compare and contrast these risk factors. So now that we were able to do this, it was a matter of which risk factors we wanted to look at, and there were 11 in total. Hypertension, alcohol, obesity, income deprivation, non-white populations, physical inactivity, coronary heart disease, air pollution, viral hepatitis B, C, and diabetes. And the definitions for all of those are on the right-hand side there as well. And again, these were taken directly from Fingertips. So in terms of our analysis, we aggregated the data using weighted averages and means for all of our unitary authorities and counties, aggregating them up to a given cancer alliance value. And we ran univariable models comparing each risk factor to the cholangiocarcinoma mortality on a one-to-one basis. And this is good theoretically, but it didn't give us an ideal look at what's actually going, accounting for the real-world confounding variables as such. So we created a multivariable model using a stepwise linear regression and variance inflation factor to kind of identify a lot of overlapping variables. For example, things like obesity and physical inactivity are known to correlate quite strongly. So this could kind of account for that with this model. We ran this, removing a lot of the risk factors that were identified in the linear regression model. And we compared these variables simultaneously in a multivariable model, and the results of which are seen here. So, having removed a large number of variables due to overlapping and confounding factors, we were left with hepatitis B and C, air pollution, and physical inactivity. And all four of those were significant in associations with cholangiocarcinoma mortality. However, in two different directions. As we can see here, the viral hepatitis B and C were negative in their correlation with cholangiocarcinoma mortality, whereas air pollution and physical inactivity were positive, essentially meaning that as hepatitis B and C rates went up, cholangiocarcinoma mortality went down, and vice versa. As air pollution and physical inactivity went up, cholangiocarcinoma mortality also seemed to track that way. And we can visualize that here with some maps as well, similar to the ones we saw earlier, that noted cholangiocarcinoma mortality and incidence. Again, darker colors indicate a stronger presence of that given risk factor here. So if we start on the right-hand side with physical inactivity, while this hasn't been directly tied to cholangiocarcinoma mortality before, it is quite an interesting new look. And again, this is very preliminary, and there's a number of different reasons this may have come up in our model. First off, physical inactivity is tied to things like obesity, as we've already mentioned, and that in turn has been associated with cholangiocarcinoma in the past. Additionally, it's also linked to poorer surgical outcomes a lot of the time, so that could be a potential explanation there. Again, quite an early finding. Quite interestingly was the association with air pollution and cholangiocarcinoma mortality. And again, this is proportional as well. So as air pollution went up, we also saw that cholangiocarcinoma mortality seemed to follow. And an interesting link here could be due to, again, a very preliminary theory, and again, just a theory, is something called the toxin theory, where as the body ingests more toxin, whether through air pollution or otherwise, they're excreted through the bile, and that with more toxins can irritate the lining of the bile ducts, potentially driving some of the changes that could lead to cholangiocarcinoma as well. Again, it's very preliminary, but might be some justification for further deep dive there. And then we had our results with hepatitis B and C, where as these increased, cholangiocarcinoma mortality seemed to drop in these cancer alliances. There's a number of reasons for this, but it does go against our current thinking, as there is a known correlation between viral hepatitis and the incidence and mortality of cholangiocarcinoma. What we thought could have been happening here was that there's potentially linked, or there is a potential surveillance bias, so a link to increased screening. Essentially, those who have hepatitis B and C are in the system as such. They're getting, hopefully, regular checkups, being seen by hepatologists and specialist clinics, allowing any changes, any potential early development of cholangiocarcinoma to be identified. Again, a working theory, but not entirely understood. It does lead on to some questions about the robustness of the data, though, which we'll cover in our limitations here, which was first off that there were a relatively small number of risk factors analysed. Fingertips does have an incredible amount of data on there, and with a future look and a deeper dive, we can find a lot more about what's going on. Additionally, as I mentioned earlier, we had to aggregate all of our data up into only 21 cancer alliances, and this essentially meant we only could compare between these 21 areas, which does sound like quite a number, but within the world of statistics, that does weaken the statistical strength of our study, meaning that we couldn't truly identify what potentially is driving this variation. It does give us a good first look, but isn't truly solid yet. To fix that, we could have accessed the National Cancer Dataset ourselves and re-accessed it. This is what the original data was accessed from, but it was beyond the pricing and the timing of this project. And finally, there was also a disparity between the dates that the data was gathered. So our cholangiocarcinoma mortality, as mentioned, was from up to about 2018, whereas our fingertips data was just after COVID. So whilst we use this as a kind of placeholder for the different like prevalence of certain risk factors throughout the country, it can't be taken as true that that would be the same thing 4 years earlier when cholangiocarcinoma mortality was being measured. And finally, also, this is a first of its kind study, so we don't have anything to really validate it against. The earlier data that compared the cancer alliances within England was again a first of its kind study, and this is truly the first one worldwide to assess what is potentially driving those regional changes. So in terms of future directions, before I hand over back to Professor Khan, with these project results, due to some of the limitations, it is quite difficult to assess the real-world outcomes. Again, there were a lot of overlapping factors, and because we couldn't re-access that data set, we couldn't truly understand what's going on. We can't have full faith in our data here. But if we had some increased time and funding, re-accessing the data set would be viable, and we could then analyze data at the county and unitary authority level with 153 data points there, which would significantly increase the robustness of our study. And from there, who knows where we could go? It could identify some new associations. We could potentially identify some new ways to go with public health outcomes as well. There's a lot of different ways that this could go should we be able to kind of access the data again. But I'll hand over back to Professor Khan to talk a little bit more now as well.
Well done, Arjun. Well. This is very preliminary data, right? But the data that we found suggests that areas where there's more hepatitis B and hepatitis C have a better survival. Now that sounds very counterintuitive, but what you have to remember is that patients who have cholangiocarcinoma often present very late, and by the time they get symptoms, the cancer is very advanced. Whereas people who have hepatitis B and C, there's a lot of screening now that happens. Everyone who comes to A&E gets tested for it. They're picked up early, they're treated early, and they're in the liver clinic. They're having regular blood tests, they're having regular scans. So you're more likely to detect the cancer at a very early stage. So maybe that's how it's explained. There is overlap between the risk factors. So, for example, if even despite the multivariate analysis, the suggestion that inactivity is associated with increased mortality from cholangio. It doesn't mean people who get cholangiocarcinoma and die from it are inactive, because there are other things that could feed into the inactivity, for example, comorbidities, the fact that they're inactive because they've got the cancer, and the worse the cancer is, the more inactive there is. And these are examples of the things that it's really difficult to tease through when you do population-wide studies. The air pollution thing was very interesting because the biliary system is a route, is a major route by how the body gets rid of toxins. So toxins are broken down in the liver, carcinogenic, harmful substances are excreted in the bile flows through the bile ducts, and so the bile duct lining is exposed to toxins, and we are all genetically different in our metabolizing enzymes and our repair enzymes, and so maybe there's a link there. That's been postulated before. So one of the other things that our original data analysis that was commissioned by the AMMF did was to find out, to show that there's difference in mortality. So there's a suggestion that there might be a difference in risk factors, but we also found in those studies that we did with AMMF and with HDI and NHS England that, and as Shane mentioned earlier, that there are regional differences in access to treatments. And so we thought, well, what do we do next? So what we are now planning to do, and this is being led by Professor Danny Gomez, who's, I think, in the audience somewhere, who's going to be giving a talk later, is doing a national audit of what happens to patients with cholangiocarcinoma when they get diagnosed. And not just in the big centres, but in every hospital. We are hoping to reach out to most of the hospitals in the country and to look back at all the patients that came in with cholangiocarcinoma over a year's period and what treatments they got and when they got them, etc. To really dig down into what's happening. And really, we need to know what's happening in the smaller hospitals, not the big centres. When it comes to the big centres, however, there is and Professor Bridgewater brought this up with Shane earlier, was the idea about having local care is fantastic, but there are some treatments that will need to be done in bigger, more centralised services. For example, how we do liver transplant. There are 7 transplants centres in the UK. So we are launching an organisational survey this week, where we're asking every regional tertiary HPB, hepatopancreaticobiliary unit in the UK, to complete a survey providing information on their teams, on their staffing levels, on their surgical activity, on their patient management, and how they follow up patients and their research activities. We're launching this survey now, which with a 3-month window, and we hope to be able to share the findings in late 2026. And parallel to this, we are shortly going to be organising an audit of all the hospitals in the UK, hopefully, or most of them, to see what the actual local practice is in every hospital, in addition to this central survey. So I just wanted to mention that as well, about some ongoing work. These are our references. And thank you. And with acknowledgements to Stephen and Wafa for their help with the project.